Hi guys, Amanda Curtis, nurse practitioner, just continuing our discussion about perimenopause. So in the last video I discussed who it affects. I also wanted to add on in conjunction to that video, perimenopause is a diagnosis of exclusion as well. Even though we know that it affects these women during this age, me as a clinician, when they come to me and they're giving me all their laundry list of symptoms and things that are occurring, I have to make sure that it's not something else. So my job when I order labs is to go in and make sure it's not something like vitamin D deficiency or iron deficiency, because the menses are all over the place. And is it a thyroid issue? So these are the things that I as a clinician am making sure that I'm checking on, because if you're vitamin D deficient, estrogen's not gonna make that feel any better. Okay, so it is a diagnosis of exclusion, but I do assume that based on a woman's age that this could be the problem. So the next definition I want to discuss is when people say estrogen. Estrogen is technically a family of estrogens. There are three that we know of: estrone, which is E1, estradiol, which is E2, and estriol, which is E3. They recently just discovered a fourth that is created during pregnancy by the fetal liver. But that's what we mean. But when we say what are we replacing, a woman during menopause, her ovaries produce estradiol. So that's what we are replacing. It's a body identical. That means it's not synthetic. The difference being, something like ethyl estradiol, which is a birth control that we normally prescribe to women during their fertile years to prevent pregnancy. That is a synthetic estrogen, okay? And then the same for progesterone. We prescribe progestins, which for birth control purposes, they are not the real deal. They are a synthetic mimic of the original. So when I think about estradiol specifically, I think of it as a lubricating as well as a growth hormone for women. So lubrication meaning we notice dry skin, we notice dry eyes, we notice, dryness in our vaginas. So when we replace estradiol, we get the lubrication back that we've had our whole entire life. So the sebaceous glands are working appropriately for all areas. The other one is a growth hormone. So it grows a baby. So when we're pregnant, that we have our highest level of estrogen during pregnancy, and so you think it's growing the blood supply to help nourish the fetus. It's growing bone, right? It's our growth hormone as well as our lubricating hormone. So some common symptoms that we can see during the perimenopause transition are going to be things, again, joint lubrication. So frozen shoulder, we can see anxiety increasing, we can see tinnitus or ringing in the ears, insomnia, changes in our menstrual cycles, irregular periods, weight gain. So this I also want to touch on, because weight gain, there's only two places in your body that you can get any kind of estrogen from after your ovaries stop producing it, and that is fat cells, and that is your adrenal glands on top of your kidneys. So when we think about why the body is holding on to weight or gaining adipose tissue during menopause, it's because it's looking for estrogen somewhere, and somehow it's going to hold on to that. And usually what it's produced is estrone, which is E1, and a more inflammatory kind of estrogen. But that's all the body can get with what it has. So the last thing I wanted to touch on is how stress affects our hormones. When I was learning all about the management of hormones, someone once told me that sex hormones like estradiol, progesterone, and testosterone are the tail of the dog. And what does that mean? It means what is wagging the tail. And the answer to that is your stress response. So there's something called the hormone cascade, and I'll post a picture of it. But everything starts off as cholesterol, and then it is converted into things like allopregnanolone and pregnenolone, and then at the end of the cascade are your sex hormones. But above it, and biologically speaking, cortisol, which is also a hormone, is produced in the adrenal glands, and it is responsible for our fight or flight response, so our stress response, and to keep us alive. So our body biologically is wired to prioritize cortisol, the production of cortisol, over the production of sex hormones. So if you are during a period of high stress where you have high cortisol, your cortisol is literally stealing the raw ingredients that are used to make your estrogen. So that's why you'll see wonky stuff happening to your periods when you're under high stress. That's why women can't conceive when they're under high stress. So you always hear about during when people are doing on fertility journeys, I was stressing about it and I couldn't get pregnant, and then all of a sudden they go on vacation and they're able to get pregnant. Why is that? Because you finally fixed your stress response, and your body's able to naturally produce the hormones that it needs to maintain a pregnancy. So that is how important stress is to managing your hormones, and that is why it's great to manage those, but it's also more important to manage your stress. So I hope some of these tips and education are helpful for you guys to help understand your body a little bit more and what our goals are during HRT replacement for our perimenopausal patients. It's really just to provide the body with enough estradiol to show it that it's safe to bring the FSH and LH down a little bit into a more regular range, and so that is the goal. Symptom management is the goal, but as we get closer and closer to that menopause transition, the dose is going to be changing. So that is why I tell you that you need to be working with a clinician who's going to listen to you, who's going to respond to you, who's going to help you change your dosage, listen to your symptoms, and adjust accordingly. So those are my big pointers and tips for your transition in perimenopause.